Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. When as I mentioned that I was asked by one of the person in the group to present something on the headache, I had an old presentation related to headache and migraines, but I never wanted to present that one. And the only reason was because I thought that was a little bit too complicated. So I will be trying to express my thoughts and feelings related to headache. It's simple C presentation. Well, these days there are so many things happening. So उसके रेफरेंस में हबीब जालिब का एक कथा है, मेरे हाथ में कलम है, मेरे जहन में उजाला, मुझे क्या दबा सकेगा कोई जुल्मतों का पाला, मुझे फिक्र अमन आलम, तुझे अपनी जात का गम, मैं तुलू हो रहा हूँ तो गुरूब होने वाला. uh, Habib Jalib was actually, unfortunately, suffering from a psychiatric morbidity, and there were lots of things about him. So when he was in a good, happy mood, a little bit hypomanic or manic mood, then of course he was writing a lot of revolutionary kathas like this. It's a very nice thing to actually read him in both the phases of mania and depression, which was actually expressing the mood states as well. So his poetry is good in that sense. I hope sometime if you have time, you can go for it. So let's do the headache, a psychiatrist viewpoints and my viewpoint related to headache. People may not agree with everything I say, but of course, I feel that I have to express myself, what my clinical experience, what the research, what the related data is suggestive of it. So let's start. Now, when we say headache, what do we mean by that? So headache is the most common reason why a patient seek for medical attention, not necessarily psychiatrists, because people don't feel that the headache is related to psychiatry. So most of these people who are having headaches, they either go to the family doctors or they go to the neurophysicians or neurosurgeons, but very less to the psychiatry. Is the symptom of pain anywhere in the region of head or neck? So this upper portion of our body, from neck up to the scalp, this is the area. If there is a pain in this area, then we call it headache. And it is classified usually into primary headache or the secondary headache. Now, whenever we say headache, there's serious symptoms related with the headaches which absolutely need our attention, the psychiatrist attention, not the, again, anybody else's attention, is that one, if the headache is recurrent, two, if it is persistent for a longer period of time, because most of these people do have taken the treatment from family doctors, they have taken the treatment from neurologists and neurosurgeons, and if it is still persisting, then people do come to us. It definitely causes a changes in personality. So if somebody is continuously having headaches, lots of personality issues comes there. Like they'll be irritable, they won't be focusing, they won't be able to concentrate on things, their day-to-day activities is compromised, their work, which is related to their productivity, that is also compromised. So lots of changes in personality and mental function occurs if somebody is having recurrent or persistent headaches. It is intense pain and it's usually unbearable. So people usually seclude themselves, they lie in bed, they switch off the lights, they try to keep themselves isolated. So that also gives rise to multiple other symptoms as well. Well, if headache is related to with the fever, and some neck pains, then of course the neurological component is there, and the neurologists have to see the reason for the fever and of course the headache. But most of the time, this is not the presenting symptoms in psychiatry. If it is traumatic associated with fever, associated with the neck pain, associated with nausea, vomiting. People don't come to psychiatrists. They usually go to the physicians and neurologists. But again, if they are not able to ascertain the reason and they feel that there are changes in personality, it's a recurrent headache, persistent headache associated with, again, some trauma, injury, nausea, vomiting, even then, the psychiatrist can play a vital role in the management of headache. And the reason why I'm saying this, I will just come to that. Primary headache is divided into 5 different kinds of classification system. One is tension type, second is cluster type, third is migraine, fourth is sinus, and fifth is thunderclap headache, which is a sudden onset, severe, excruciating pain in the upper region, which comes and then it goes. So those are various kinds. There are multiple ways people have classified the headache, but generally, International Headache Society classification system is accepted everywhere, and they divide headache in the same situation as primary or secondary. Primary is migraine, when there are two most common types. Tension headache is the second. These are the two most important. So migraine or the tension headache are common. Trigeminal neuralgias, autonomic cephalgias are relatively less, but they are also again there. And it presents with cluster headache, paroxysmal or continuous hypercrania, short-lasting neurological form headache attacks with conjunctival injection and tearing. Then there are physical activity triggered, physical stimuli triggers, primary stabbing, head injury, etc. Now, the secondary headache is usually secondary to other causes like trauma, vascular disorders, non-vascular disorders, substance abuse and withdrawal, medication induced or medication overuse, infection. And then there are disorders of homeostasis. There is headache causing excluding CNS, so some systemic diseases which can lead to headache, and there are psychiatric causes and the cranial nerve disorders. If you look at this, it appears as if most of the types of the headache are organic in nature. But when you go to actual life situation, most of the headache is psychological in origin. And why I'm saying that, I will come to that as well again. Whenever a person presents to you with headache, some of the key features that you have to identify is how it began, what are the precipitating events, illness, injury, frequency and pattern, location, time to peak intensity, duration, quality and intensity, warning symptoms, associated symptoms and level of disability, and triggers and aggravating and relieving factors. Now, this is basically the headache history, which all of you should be able to understand and follow it. The frequency, location, time, duration, quality, warning symptoms, associated symptoms, and triggers. Those are the things that you need to know. An easy way to remember it is a word we call Socrates. Socrates is site, onset, characteristic, radiation, associated symptoms, timing, exacerbating and relieving factors, and severity. So the word Socrates is easy to remember. Socrates, site, onset, characteristic, radiation, associated factors, timings, exacerbation and relieving factors, and the severity of the headache. So this is easy way of remembering, and this is how you have to take the history from a patient who was presenting with the headache. Again, Fakir Saab ki ghazal hai, and it was sung by Jagjit Singh and Chitra Singh long time back, and recently, in probably 2-3 years ago, Sajad Ali and his daughter sung that as well in a little bit modern version of it. I like the way it is said, and and it's basically applies to lots of people around you. इश्क में गैरत जज्बात ने रोने ना दिया. So I hope you'll be able to hear it sometime on my request and feel the emotional pain. रोने वालों से कहो उनका भी रोना रो लें, जिनको मजबूरी ये हालात ने रोने ना दिया. तुझसे मिलकर हमें रोना था, बहुत रोना था, तंगी वक्त मुलाकात ने रोने ना दिया. So it's a beautiful ghazal. Primary headache, if you look at your skull, and so there are various type of structures here, and it's a very complicated small organ of the body. Starting from the skin, then there are muscles, then there are fats and other associated supporting structures here. Then going down, there are bone, then there are dura, arachnoid, pia mater, then the brain structure. Brain structure itself includes vascular system, venous system, which is, and the lymphatic system and all that stuff. This face or jaw also have lots of muscles, which are very small and very sensitive, and it has lots of glands in it. Then there are dentures in your mouth, and there are again auditory meatus and the cavity, which also have certain features of pressure effects there. And then we have eyeballs, and eyeballs are actually again very sensitive, and lots of time the headache is related to them. If you have visual problem, if you have raised intracranial pressure, if you have some other issues related to optic nerve, then when the optic nerves goes back into the chiasma, there is a small window from where the brain and the eyeballs are connected through an opening. And of course, lots of time, something happening inside the brain can give rise to symptom of the eye as well. So always remember that this is a very complex, complicated portion of our body, and it has so many structures that pointing out to one thing which is causing the pain is sometimes difficult. So it's not necessarily that it's only one thing. But usually, when we say that it's a sinus headache, it's usually in the front of the face and not actually on the head and the neck. It's always on the front of the face. So if you can look at the pictures, it's the upper part of the forehead, and there is a maxillary sinus and nose area. When we say cluster headaches, usually clusters are always related to eyeball and unilateral on one side only, and giving very excruciating and pain around the eye. So that is very sensitive as well. Tension headache is usually around the head, around the muscles of the head, usually on the forehead, but it can be on the sides. It can be on the nape of the neck as well. So that is also tension headache. And migraine, we always know that it's unilateral. It is associated with visual and auditory aura. There is definitely a very typical classic presentation when we say that it's migraine. So it's not difficult to identify a migraine if it is unilateral, presenting with aura, some predisposing factors and some precipitating factors, and also nausea and associated symptoms with it. So it's relatively easier. But when migraine is not very typical, then of course things do get complicated here as well. So when I was saying to you about the muscles, look at the amount of the muscles in the body. So these plus signs shows that these are very sensitive, thick, very again too much muscular on the face, too many muscles on the face. Like if you see the forehead here, then it's nape of the neck. You see lots of muscles, neck. Then there is temporalis, then temporalis and the neck muscles coming down from the head region, then temporalis alone, then there are frontal muscles, then there are frontal and on the side of the muscles of the scalp and upper region. And so trapezius, sternocleidomastoid, temporalis, superficial masseter, levator scapulae, suboccipital upper trapezius, suboccipital muscles, and superior oblique. All these muscles are actually in layers around this area. And whenever I always give an example that if you, to my patients, that if you keep your arms raised like this for a longer period of time, say maybe 5-10 minutes, it will start aching, it will get fatigued. These muscles are very sensitive to our emotions and to our day-to-day activity. And when these muscles, any muscle like superior oblique muscle, if it gets in a state of tension, lasting for a few minutes, then it will start aching and it will give rise to a headache. So accepting the fact that the headache is common, you have to understand various muscles around the scalp as well. Trapezius, sternocleidomastoid, temporalis, superficial masseter, superior oblique, levator scapulae, suboccipital, upper trapezius, and suboccipital muscles. All of these muscles play a role in generating symptom of headache. Giving you further examples like common locations of the migraine headache, tension headache may also be unilateral. So the tension headache, when we say that the headache is again on only one side, it not necessarily it is a migraine. It could be only the tension headache as well. And if it is a tension headache, it is then difficult to differentiate between tension headache and a migraine. But the migraine is usually associated with symptoms like nausea, like flashes of light, like aura, like other predominant symptoms. So then, if this headache is not associated with any other symptom, then it's relatively easier. Atypical migraine and the tension headache sometimes are difficult to be differentiated and assessed. So it will take you a lot of time. But headband distribution and occipital distribution, we definitely know that they are not migraine, but they are the tension headaches. Now, the reason why I say that the psychiatrists are involved a lot with the headache presentation is that it is the most of the research suggests that this is one quote: 70% of the headache is related to tension headache. And when I say tension headache, means the muscles and the upper part of the head and neck. 70%. This specifically says 70%. If you go to various studies, the figure vary anywhere between 70 to 97%. Now, if we accept this range, this means that 70 to 97% of the people who have headache, they need psychiatric intervention and not neurological or anybody else's intervention. But of course, as I mentioned to you, that most of the people end up with psychiatry. By the end, if everything fails, then usually they end up with psychiatrists. Then it's, of course, more difficult for you to understand what to do about it. Then a migraine is only 15%, and cluster headaches and sudden onset headaches are usually very less, 0.1 to 0.01%. So if you are seeing 100 people, out of them, 70 to 97% people have tension headaches, and you are the one who should be treating it. Only some of them, have 15% of them, have migraine headaches, and they need to be treated by the neurologist. Cluster headache and sudden onset headaches, of course, again, neurological problem, and we don't have anything to do with it, except that we should be able to assess and evaluate. When I say migraine, four important parts, components of it. One or both sides of heads are involved. It lasts from 4 to 72 hours. It is never, ever more than 72 hours. And 72 hours means how many days? 5, approximately 5 to 6 days. It never lasts for months. Then it is usually moderate to severe. In some cases, it could be mild. And over-the-counter medications usually are taken for this kind of headache, and it subsides within a week's time. Tension headache, on the other side, if you look at that, it is again involving one or both sides of the head and neck. It lasts for just 2 hours, so less than the migraine. So if there is a migraine, it will last for 4 to 72 hours. But the tension headache usually lasts for only a couple of hours, and then it is relieved, and then it may come back again, but it never lasts for longer periods of time. Continuous headache for days, we should think about migraine rather than. But most of the people, they are not able to express themselves about the headaches that they always say that I have headache, excruciating pain in the upper head and neck, and it is for days and days. But when you go into the minor details of it and take a detailed history, you will be able to understand that, okay, fine, this headache lasts for a couple of hours, then it disappears, and the day is going by comfortably, and then it comes back again, and people say that it is always there. It is not actually always there. And the tension headache is never ever severe enough to make them stop everything, lie down on bed, switch off the lights, and do nothing for days. For days. They can go switch off the light, lie down on the bed for hours, but not days. In migraine headaches, the severity is so intense that if they seclude themselves into a room, switch off the lights, and are just isolated, it can last for days in bed, and they are not able to do anything, any job, any household chores, even to self-care gets compromised. And usually, again, people do take treatment for tension headaches from prescribers, family doctors, and the neurologist, and they don't get better if the treatment is not appropriate. Sinus headache, as I mentioned, unless or until the infection of the sinus is treated, it won't go away. It is usually treated with the disc decongestants. It is mild, and it lasts for days and days if untreated. So once the sinus headache starts, and if the sinuses are not appropriately treated with the decongestants and antibiotics, then this can last for more than 72 hours, and it will be there till the time the sinus is absolutely treated. Cluster headache, one side extending from behind the eye, lasts for 30 to 90 minutes. It's very severe, and the best treatment is oxygen therapy and the triptans. So that is one of the, again, situation. In migraine, there are 4 phases. Now you have to understand these phases. One is the prodrome. So people would be able to understand that there are warning signs before the headache starts. So they have problems in concentration, irritability, depression, difficulty in speaking, reading, sleeping, yawning. They have nausea, they have fatigue, they are sensitive to light and sound. They have food cravings. They want to eat sweets, especially the chocolates and the mithai and all that stuff. They have increased urination, and they have muscle stiffness as well. So that is the prodrome. Now, the prodrome is not only the feeling, it could be anything. It could be troubles in sleeping, yawning, fatigue, nausea, food cravings, urination, and muscle stiffness. So there are a whole range of symptoms. But whenever a person starts having these premonitory phase of migraine, then of course, then there are associated things with it. Aura, seeing bright light, flashes, dots, sparkles, or lights. Then the blind spots in your vision, numb or tingling skin, speech changes, ringing in your ears, tinnitus, temporary vision loss, seeing wavy or jagged lines, and a funny feeling. So you are not able to understand what is happening to you, but you do feel that there is something happening. and you are not able to express it as well. So that is also headache. Aura in migraine. Then actual bout of the headache is sensitive to light, noise, and odors. So I won't be able to tolerate the smell of the food which is cooked at home. So most of these women who have actually migraine, they usually are not able to go into the kitchen. They are not able to wear any perfumes or colognes. So if you see a person who's wearing a perfume, who's wearing a cologne, then definitely it's not migraine. If the person is able to go into the kitchen, cook some meal, or he's able to move around, then it's not migraine. In migraine, people usually, it's so devastating that they are not able to tolerate these kind of things. Feeling very warm or cold, pale skin colors, feeling tired, there are speech changes, there are tender scalp, diarrhea, and fever. But the diarrhea and the fever are relatively less common as compared to any other thing. And post-drome, after the headache is gone, 4 to 72 hours, the duration I mentioned earlier, they are unable to concentrate. They are feeling depressed, tired, fatigued, not able to understand the things, and feeling strange, euphoric, strange kind of a feeling. Any questions so far? So I could see that there are some few comments on the chat box. So let's see that. Vomiting in migraine is due to increased intracranial pressure. What to do if we have migraine in exam day? Okay. Usually migraine is not there in the exam day. It's always a tension headache, as I mentioned, which is most common. And of course, yes, the treatment, I will come to that as well. नासिर क्या कहता फिरता है कुछ ना सुनो तो बेहतर है दीवाना है दीवाने के मुंह ना लगो तो बेहतर है कल जो था वो आज नहीं जो आज है कल मिट जाएगा रूखी सूखी जो मिल जाए शुक्र करो तो बेहतर है बट हम शुक्र ही नहीं कर पाते बाकी सब कुछ कर लेते हैं anyways coming back to the migraine headaches there are definite triggers for the migraine as well. So Dr. Saab was asking about the exam. So exam cannot trigger migraine, but yes, stress can. Usual triggers are menstruations, pregnancy, contraceptives, foods like chocolate, cheese, again, and some other compounds containing the nitrites, alcohol. Clinically, usually if there is no aura, then there is a slow onset, unilateral, pulsating with nausea, vomiting, and photophobia. If there is an aura, then usually headache follows aura within 30 minutes. Within 30 minutes of those symptoms of lack of attention span, unable to tolerate the cologne and the perfumes and the smells, usually the headache starts. So people are able to know and they are able to do something about it. So usually people do take the medications for it if it is there. Aura develops over minutes and it is reversible. Visual, most common scintillating scotomas. So there are definitely blind spots in your visual field if it is really a migraine. Otherwise, it won't be a migraine. So motor symptoms, there are hemiparesis, ophthalmoplegia, aphasia, sensory hyperesthesia, dysesthesia, and brainstem vertigo and ataxia as well. So these are very typical migraine attacks. Migraine characteristics and tension characteristics. So I'm coming to the answer question that you have asked about the exam. So migraine is characteristic, the headache attacks lasting 4 to 72 hours, unilateral in location, pulsating sensation, moderate or severe pain intensity, aggravated by routine physical activity, accompanied by nausea or vomiting, sensitivity to light or sound. And on the characteristic tension type headaches lasting from 30 minutes to 7 days, but usually 30 minutes to 2 hours, bilateral in location, pressing or tightening sensation around the head, mild or moderate pain intensity, not aggravated by routine physical activity. So if a person is able to do the routine physical activity, I usually exclude migraine because migraine is very, very severe, intense headache, which makes you go off everything. And then nausea or vomiting is usually not seen, and sensitivity to either light or sound is also not there. So that is a tricky situation. Now, the tension headache, forehead, migraine, unilateral, cluster headache, eyeball, sinus headache on the sinuses, then hypertension headache, nape of the neck, and temporomandibular joint is usually the headache is here. Just at the end of the eyebrow, these are temporomandibular joint abnormalities like bruxism. In psychiatry, you see lots of people grinding their teeth. They start developing these headaches. And the examination of the dentures is the best thing to evaluate bruxism and TMJ headaches as well. Now, tension headaches, as I mentioned, usually most common type of headaches. Worse at the peak ages of young adulthood, working age, 30 to 40 years. Duration is 30 minutes, rarely daily. Exertion does not exacerbate the pain, no nausea, vomiting. NSAIDs are usually prescribed, but I don't agree with NSAID's treatment in tension headaches. So uh, amitriptyline is given usually, tricyclic antidepressants. So there is basically a good thing to evaluate the headache if you give the chart, course of an attack to a patient. Ask them from Monday to Sunday, 7 days a week, and timings written in front of it. When exactly the headache started, for how long it lasted, and when it disappeared. If you'll be able to draw that chart for a week for a headache, you will be absolutely able to understand the course and the outcomes of the headaches, and the diagnosis is much, much easier. Much, much easier. Now, common treatments for the migraine or again headaches. Migraine, as I mentioned, severe excruciating pain and usually treated by neurologists. We psychiatrists, I don't prescribe triptans to my patients, so because I don't have that expertise to prescribe the triptans. Very seldom, very, very seldom, maybe once in a 10 years time I have given triptan to somebody, but usually I don't prescribe it. If I make a diagnosis that this is migraine, then I always refer the patient to a neurologist because they are the best people to treat the migraines, not me, myself. Pain relievers like NSAIDs and other drugs may be helpful, but the target medications are actually three medications that are. One is triptans, and I think three different types of triptans are available in the market in Pakistan. And then second treatment is valproate. Divalproic sodium is given for prophylaxis of migraine. And a combination of naproxen sodium and divalproate, or combination of naproxen sodium with triptans is considered to be the best treatment for migraine. But of course, it's not my area of specialty, so I don't want to talk much about it. Botox shots are also given to some of the people who are not responding to conventional medications like triptans and SAIDs. The first and the foremost target is to break the cycle of the headache. And to break the cycle of the headache, you can use multiple things like dihydroergotamine, valproate, levetiracetam, lidocaine, magnesium sulfate, and sometimes ketamine is also given for these type of headaches. But again, not my area of expertise, so I cannot say anything about. कब से अपनी तलाश में गुम हूं, ऐ खुदा मुझको मुझ पर अफशा कर दे. कौन बांटेगा दुख तेरे नासिर, दोस्तों से भी छुप के रोया कर. Okay, now how to cure your headache naturally? Lots of people in the market, they promote naturopath, they promote lots of other things. What I have found in psychiatry which helps is these are the 5 or 6 things that I always suggest to my people who are coming with the headaches or most of the psychiatric symptoms as well. Again, uh, tea should be taken in moderation. Don't take more than 2 cups of tea in a day. That is very, very important. It is stimulant, it helps headache, but don't take too much. How it helps headache? Because it has caffeine, and caffeine is a stimulant, so it can help headache. But usually, a warm water, but not more than 2 cups of tea. If you have taken the tea, then you should not take the coffee. Some people take 2 cups of the tea, 2 cups of the coffee, and then 2 cola drinks as well. No, it has to be only two a day, either a tea or combining tea or coffee, or maybe one tea, 1 cup of cola drink, not all of them together. Stay hydrated. So, correcting the hydration level of your body is the best. And religiously speaking, it helps as well. So, if you feel uncomfortable, anxious, worried, headache, drink a glass of water. Maybe one. If not one is helping, try two. If that is not helping, try three. People drink lots of chilled water, with lots of ice. Sometimes it's helpful, but usually lukewarm water or the tap water is recommended. Get away. So distraction is the best strategy. If you are doing this thing, just leave that thing, start doing something else. Sleep is the best possible treatment for most of the types of the headache. If you can sleep and have the possibility of sleeping for 8 hours of the night sleep, it will definitely relieve the headache in most of the situation. Meditation, so people do yoga, people do exercises. I always recommend a brisk walk for 30 to 45 minutes to my patients, and it definitely improves lots and lots of things as well. As far as the medication is concerned for headache, analgesics is just one component. Best analgesic, plain simple paracetamol, or plain simple Disprin, or plain simple ibuprofen, not combining the drugs together, because that makes things more complicated and difficult to assess the patients as well. If they are taking paracetamol plus or something like that, then usually it's complicated. Then ergot alkaloids, the old-time medications are given for migraines. NSAIDs, including aspirin, diclofenac, ibuprofen, naproxen, are helpful. Opioid, lots of people do give opioids. I am not in favor of giving opioids to any of my patients having headaches or pain symptoms. Triptans, again, best treatment for migraine, and the neurologists are the best people to prescribe them. Zolmitriptan is considered to be the best, but I don't know about the others. And a combination treatment is usually prescribed as well. So lots of other medications are used for headaches as well, like beta blockers, like tricyclic antidepressants, angiotensin blockers. Then there are second line drugs, which are anticonvulsants, divalproex, topiramate. Then there are Botox injections, riboflavin, magnesium, and all that stuff. But most of these treatments are usually vary from patient to patient, intensity of the symptoms, severity of the headache, but if the headache is 70 to 97% tension headaches, then the best treatment is to assess them for psychiatric morbidity. And if you get something out of them that this person is having anxiety disorder, OCD, major depressive disorder, phobic anxiety disorders, social anxiety disorders, then of course the treatment is much more easier for a psychiatrist than to treat anything else. जाते जाते आखिरी शेर ये पहले भी कई दफ़ा पढ़ चुका हूँ और मुझे ज़बानी कभी नहीं याद हुआ, बट महानूर को ज़बानी याद हो गया। कभी अर्श पर, कभी फर्श पर, कभी उनके दर, कभी दर बदर, हमें आश की तेरा शुक्रिया, हम कहाँ कहाँ से गुजर गए. Well, thank you very much. This was it for today. Now the questions. Can tension headache be part of somatoform disorder? Yes. Lots and lots of time it could be, because again, as I mentioned to you earlier, that usually, most of these headaches have psychiatric morbidity, and you should assess them for anxiety disorders, somatoform disorders, and other disorders as well. Even in usually we do see lots of time some other symptoms associated with them as well. So yes, they can be there. Any other question?
Yes, sir.
Hmm.
सर वैसे तो मेरा क्वेश्चन ऑलमोस्ट आपने आंसर कर दिया है, लेकिन सर जैसे हम जब ओपीडी में प्रैक्टिस करते हैं तो हमें अक्सर न्यूरोलॉजी ओपीडी से रेफरल्स आते हैं जिस पे मतलब उन्होंने डायग्नोसिस बनाया होता है या टेंशन टाइप हेडेक या मिक्स्ड हेडेक, ठीक है, और हमने पेशेंट को देखना होता है और बहुत बार ऐसा होता है कि जो टीन एजर्स होते हैं ना, मैंने नोट किया है जैसे अराउंड 16-17 ईयर्स ऑफ एज होते हैं पेशेंट्स, वो बहुत ज़्यादा प्रेजेंट करते हैं इन कंप्लेंट्स के साथ। अब जब हम टेंशन टाइप हेडेक देखते हैं तो टेंशन टाइप हेडेक को आइडियली ट्रीट करना किसका डोमेन है? जैसे अगर हमारे पास ये क्या या ये लाइजॉन वाली चीज़ है, मतलब देखें अगर न्यूरो से हमारे पास पेशेंट रेफर हुआ तो व्हाट शुड वी डू आइडियली, कि हम बस असेस करेंगे अगर हमें कोई और कोमॉर्बिडिटी कोई और एसोसिएटेड सिम्टम्स नहीं मिलते तो हम क्या पेशेंट को रेफर बैक कर देंगे या हम टेंशन टाइप हेडेक ट्रीट कर सकते हैं? आई एम ऑलवेज कंफ्यूज अबाउट दिस, और मतलब मुझे
तुम
ये लग
मेरी
रहा था कि
तुम मेरी लड़ाई करवाओगी न्यूरोलॉजिस्ट से, है? अगेन आगे मेरी स्टेटमेंट बहुत सारे न्यूरोलॉजिस्ट को बहुत बुरी लगेगी जब मैंने कहा कि 70 to 97% ऑफ द हेडेक इज एक्चुअली अ टेंशन हेडेक व्हिच इज रिलेटेड टू साइकियाट्रिक मोबिलिटी. Whenever you get a patient, and especially the patient is a younger person, like you said, early teens, late teens, or mid 20s, then of course tension headache is one of the diagnoses. And if they made the diagnosis, then your job is much easier. You will assess them for psychiatric problems and you will treat the psychiatric problems. That is the best option. I refer people of headache only when I feel that this is migraine. I usually don't want to treat migraines. I don't want to treat headaches associated with some organic disorders. If a person is having raised intracranial pressure and cluster headaches and some other symptoms associated with it, I usually don't want to treat them. Even then, even though if they are having depressive symptoms, if my diagnosis for the headache is migraine, along with depressive symptoms, I will definitely treat the symptoms of major depressive disorder, but I won't treat the cluster headache or the migraine headache. If you say that this is a mixed type of headaches, then he's my patient. I will definitely assess him for anxiety and depressive disorders and other psychiatric morbidity and treat it. And 90% of the cases, the headache goes away. So tension headaches, psychiatrist role. Rest of the headaches, neurologist role. Simple rule. 70 to 97% of the people who are having headaches, they are my patients. Less than 3% of the people, up to 15% of the people are the neurologist domain. Answer हुआ?
जी 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 सर, थैंक
लड़ाई नहीं करवाना. जी उस्मान, you wanted to ask a question.
थैंक यू सर फॉर द प्रेजेंटेशन, बहुत अच्छा था सर. एक क्वेश्चन मेरा ये है कि कुछ पेशेंट्स हैं जिनकी ऑलरेडी ट्रिप्टेंस चल रही हैं, पर वो आते हैं किसी और मूड डिसऑर्डर या एंजाइटी डिसऑर्डर्स के साथ हमारे पास, तो क्या ट्रिप्टेंस की डोज चेंज करनी या कंटिन्यू करनी, उसके लिए हमेशा रेफर बैक करेंगे या फिर हम कंटिन्यू रख सकते हैं? तो क्योंकि
It's unfortunately a very bad situation, Usman. And honestly speaking, I always feel bad about it. Lots of people comes to me with multiple medications they are taking from physicians. Like they have a prescription of a physician, they will have a prescription of a neurologist, they will have a prescription of a orthopedic surgeon, and they are on a mixture of hordes of medication. And when I see them, I feel that, okay, fine, this gentleman is suffering from major depressive disorder, or maybe, again, somatoform disorder, or hypochondriasis, or any other disorder, and they should not be taking so many medications. So what I usually do is I cut the medications down. I try to treat my morbidity, taper off the rest of the medication. If the patient settles down in 6 to 8 weeks' time with appropriate therapeutic dosage of an antidepressant or whatever my diagnosis is for that specific problem, if the patient recovers, the rest of the medications goes away. You see, combining treatment is always a rule when you are not able to establish a diagnosis. If you are able to establish a diagnosis, there is no way that you will be able to combine the medications. You combine medications only when you are not sure what is happening to the person. And majority of the time, I always say, मेरा उस्ताद हमेशा ये कहते थे, अल्लाह जन्नत नसीब करे, कि वो कहते थे कि ये अगर किसी नुस्खे पे एक दवाई है और डायग्नोसिस है, दैट इज द बेस्ट. अगर दो दवाइयां हो गई तो आप सोचें कि दो दवाइयां क्यों दी गई. अगर तीन हो गई तो आप लाजमी क्वेश्चन करें कि क्या इस शख्स का, इस फिजिशियन का डायग्नोसिस स्टैब्लिश हुआ कि नहीं. सो आइडियली स्पीकिंग, well, comorbidities are there, of course, but we do have to treat the comorbidities accordingly. So my patient who is suffering from depressive disorder can have diabetes and can have hypertension and can have hyperlipidemia as well. But that is usually we understand and we proceed with it. But if somebody is taking, say, आज भी मैंने एक नुस्खा देखा उस पे कैल्शियम की गोली, विटामिन की गोली, पेन किलर, मल्टीवाइट और again some few other drugs. So there were 7 medications. And when I assessed the patient was actually having major depressive disorder. So what was my idea? The lady was having OCD. So I said, well, if you're suffering from OCD, let's get rid of all the medications. Some of them needed to be tapered off. Some of them I was able to stop them right away. I gave them the treatment for OCD. Once I will be able to treat OCD, and even then, if there are physical symptoms related to some organicity, I will definitely refer them back. But if I'll be able to treat the OCD and the symptoms disappear, then I don't have to refer them anywhere else. Referral is an excellent way of achieving the targets of remission. Referrals are not good ways of assessing and evaluating the patient. If you can establish a diagnosis, then there is no point in referring a patient. If you are not able to establish a diagnosis, assess the patient over the period of time, because you are a physician. You can examine a patient. You can do the neurological examination. That is part of your exam situation, that you should be able to do the neurological examination. If you find out that, okay, fine, this gentleman is suffering from cranial nerve problems, it's not my case then. He should go to the neurologist. I won't treat them. If the patient is having migraine, I have assessed the patient and the patient is having absolute no doubts about the migraine, I will refer them. But if the patient is having comorbidities, again, I will treat my morbidity and I will definitely request the physician to cut down the medication. But in most of the situation, in real life situation, we are not able to do that. So I usually tell my patients to cut down the medications and take the simplified version. अब हमारे यहाँ एक और बड़ा मसला है ऑफ द रिकॉर्ड कि जैसे जैसे एज बढ़ती है मॉर्बिडिटीज भी कंबाइन होती चली जाती हैं और आप फिजिशियंस के नुस्खे देखें उन पे 10, 12, 14, 16 दवाइयाँ लिखी होती हैं. I don't feel like that. In old age, the liver is compromised, the kidneys are compromised, the heart is compromised. And if you give more and more and more medication to them, it's devastating. I don't want to give them too many medications. So coming back to your question, when should you refer back? If you have assessed a psychiatric morbidity, treated it, and there is a symptom remission, don't do that. If you feel that you have assessed the psychiatric morbidity, intervene, and the patient is responding to your treatment, and he is having some comorbidities that needs to be addressed, yes, refer them back. Got the answer?
Yes, sir. Sir,
perfect.
Good clinical approach. Thank you. I'm clear.
You're welcome. Any other question? Okay. If there are no more questions, okay, there are 2 questions. While taking history of one of the symptoms of the headache, then Socrates will be a part of HOPC. Yes, it can be a part of HOPC. Yes, history of present illness includes Socrates. So when you are taking the history of the headache, you should go for everything. It doesn't require any examination. And then, sir, are SSRIs indicated for tension headaches? Because I have seen many neurologists are treating tension headaches with SSRI. If you are treating tension headaches with SSRIs, then it's your domain, not a neurologist's domain. This means that probably the person is suffering from some psychiatric morbidity, and if you are not able to assess the psychiatric morbidity, then the patient will never ever get better. So most of the time it clicks, yes, the patient is having depressive symptoms, somatic symptoms, and the neurologist gives the SSRI, and the depressive and the other symptoms, they do get better. So they feel confident that they are treating the right thing. But ideally, no. Establishing a diagnosis, like I've given you the example, the patient was taking medication from a physician, neurologist, and orthopedic person, but this person was suffering from OCD. I treated OCD and everything will be okay, right? Who else raised the hand? Guest user. Go ahead.
सर मैं कहीं ना हो वो मेरा अकाउंट लॉगिन नहीं हो रहा था इसलिए
अच्छा, ओके, गुड टू सी यू. हाँ, बोलो.
मेरा क्वेश्चन ये था कि वैसे मैंने तो क्लिनिकली अभी रेयरली ऐसा देखा नहीं है या मुझे याद नहीं है कि किसी पेशेंट में सिर्फ आइसोलेटेड हेडेक या डायग्नोसिस आपका सिर्फ टेंशन हेडेक बनाओ या सिर्फ मिग्रेन. देयर ऑलवेज मोस्ट ऑफ द टाइम तो साइकियाट्रिक कॉम्प्लिकेशंस होती हैं या कोमोबिलिटीज या कुछ और. आपने कोई ऐसा पेशेंट देखा जिसमें सिर्फ मतलब आपका डायग्नोसिस इज जस्ट क्लस्टर हेडेक या जस्ट टेंशन हेडेक और उसको कोई और सिम्टम्स ना हो?
Tamina, as I mentioned earlier, that most of the time we are the last people to be seen by the patient because it is stigmatized. Psychiatrist के पास जाना है, तौबा करो, अल्लाह माफ करे, psychiatrist की तो जरूरत ही ना पड़े. मतलब ऐसे साइकाइट्रिस्ट को ट्रीट किया जाता है जैसे हम कोई एलियनेटेड मखलूक हैं जिनके सरों पे सींग निकले हुए हैं. और मैं अक्सर अपने स्टूडेंट्स को यही पूछता हूँ कि मुझे 33 ईयर्स हो गए साइकाइट्रिक प्रैक्टिस में, क्या मैं तुम्हें पागल नजर आता हूँ? जो ये बात मशहूर है कि साइकाइट्रिस्ट खुद आधे पागल हो जाते हैं. सो दीज आर जस्ट अगेन एक्सक्यूजेस. हमारे पास पेशेंट जब पहुंचता है ना तो उसको क्रॉनिसिटी बहुत हो चुकी होती है. एंड आई एग्री विद यू कि वो जो एक आइडियल सिचुएशन होती है कि एक फैमिली डॉक्टर ने पेशेंट देखा और उसको लगा कि ये टेंशन हेडेक है और उसने साइकाइट्रिक के पास रेफर किया और साइकाइट्रिस्ट ने अपनी असेसमेंट की और डायग्नोसिस एस्टैब्लिश किया और टेंशन हेडेक को ट्रीट कर दिया, वो बहुत कम नजर आती है. 99.9% नजर ही नहीं आती. सो हमारे पास पेशेंट हेडेक के साथ प्रेजेंट नहीं करता. हमारे पास पेशेंट प्रेजेंट ही तब करता है जब उसको कोमोबिलिटीज होती हैं या उसको कोई भेज दे हमारे पास कि तुम्हारे सर की दर्द ठीक नहीं हो रही, जाओ जाके साइकाइट्रिस्ट को दिखाओ जान छुड़ाने के लिए. इट्स नॉट अ गुड सिचुएशन ऑनेस्टली स्पीकिंग. साइकाइट्रिस्ट के पास आप मरीज को भेज रहे हैं अपनी जान छुड़ाने के लिए क्योंकि पेशेंट आपका सर बहुत खा रहा है. दिस इज नॉट अ गुड वे ऑफ डूइंग इट. सो अगेन यस, आई एग्री, मेरे पास आइसोलेटेड पेशेंट विद द टेंशन हेडेक नहीं आएगा. बहुत रेयर आएगा. ज़्यादातर वो फिजिशियन के पास जाएगा, न्यूरोलॉजिस्ट के पास जाएगा, न्यूरोसर्जन के पास जाएगा और लोगों के पास जाएगा. मेरे पास उस वक्त आएगा जब सब तरफ से धक्के खा चुका होगा. तब तक ऑब्वियसली साइकाइट्रिक मोबिलिटी भी ज़रा क्रॉनिक हो चुकी होगी अनफॉर्चुनेटली. और फिर जाहिर ऑब्वियसली जब मैं साइकाइट्रिक असेसमेंट करूंगा और उसको ओसीडी निकलेगी या जीएडी निकलेगी या कोई और डिसऑर्डर निकलेगा तो मैं उसको ट्रीट करूंगा, हेडेक ठीक हो जाएगी. सो आई एग्री, यस इट्स अनफॉर्चुनेट बट इट इज़ ट्रू. पहली प्रेजेंटेशन में हमारे पास पेशेंट नहीं आते. राइट, ओके, आई होप द हेडेक presentation was acceptable. I know that lots of people won't agree with my thoughts because I was talking a little bit odd about the other people in my in other specialty. I don't want to offend anyone, but there are certain gray areas where the symptoms are overlying each other. I always suggest and recommend to all of my trainees, establish a diagnosis, then write the treatment. If you are not able to establish a diagnosis, don't write the treatment. And non-pharmacological methodologies are usually very helpful in majority of the situations. But how you convey the strategy of non-pharmacological interventions, that matters a lot. हमारे यहाँ मरीजों को ये होता है कि डॉक्टर के पास गए तो गोली तो लिखवा के ही आएंगे. Not necessarily. If you feel that this disease or diagnosis don't need otherwise goli, don't give it. So always practice with authenticity and force rather than confusion. Okay, thank you very much everyone for coming in. I know it was Saturday evening and people were busy and having dinners and all that stuff, but I am thankful that at least kuch log aa gaye. Good to
Thank
see
you,
you and
sir.
hope to see you again. And please remember, exam में अगर time है और candidates present करना चाहते हैं, तो I'll be very happy to do that. Okay? Thank you. Take care. Allah Hafiz.